Thank you, Dr. Hamid. You know, I have been here a lot, and every year, I'm absolutely humbled at the caliber of the speakers. I mean, these are fantastic doctors, brilliant researchers, and amazing physicians. And I'm also humbled at the questions that we get from the patients and family members, and the courage, just talking to you guys of you guys going through the treatments and going on these clinical trials. And it really is, I think, an inspiration to all of us to keep on doing what we're trying to do. So thank you, guys. So today I'm going to be talking a little bit about uveal and mucosal melanoma. In school, I never was a big fan of class participation, but just out of curiosity, I'm going to force you guys to do it. How many folks here knew that melanoma could arise in the eye before? So that's actually a fair number. And then mucosal melanomas are melanomas that arise from the mouth or the anorectal area or the vulvovaginal area. How many folks knew that melanoma could arise there too? So this audience is always, it's always a very incredibly well-educated audience because most people, a lot of doctors don't know that these things exist. Before we can actually work to develop effective therapies for this, people have to know this exists. Otherwise, we're not going to get anywhere. And so that's why I'm really pleased to today talk a little bit about this. One thing that's really important to know, and again, this audience knows that, all melanoma is not the same. And that's true of skin melanoma. So melanomas arising from the scalp or sun-damaged skin, totally different than melanomas arising from covered parts of the body. Melanomas arising from the eyes and mucosal membranes are totally different. How are melanomas different? Well, one is appearance, or where does it start? This matters because the appearance, the location, it's important for how we diagnose these things and how we manage them. If a melanoma occurs on the thigh, we can do a big surgery, get very clear margins. That increases the likelihood of getting rid of this altogether. But if a melanoma occurs in the sinuses, in the head, it's very hard to clear the melanoma and get that nice rim of normal tissue out to decrease the likelihood of it coming back. So there are additional complications that may arise depending on where the melanoma happens. But perhaps most importantly, the biology is completely different depending on where these melanomas arise. Right? So, skin melanoma, we all know this is related to UV sun damage in various ways. But if a patient develops a melanoma in the anorectal region, well, there are not a lot of people out laying on the sun getting a lot of UV radiation there. So the reason why that melanocyte becomes melanoma is totally different. The genetic changes that allow that cell to grow, the biology, the way it behaves, also is completely different. And so when we look at melanoma, most of the melanomas we see are these melanomas arising from what we call non-sun damaged skin. Although it's UV related, men tend to develop these melanomas on the back, and we're generally wearing shirts usually, and women tend to develop on the trunk and on the thighs. Usually these are covered areas, so there's a little bit of a paradox there. A smaller percentage of patients will develop melanomas in these sun-damaged areas, and for those of you who play golf, a lot of the folks in Florida who are out there a lot, they'll develop melanomas on the scalp and so forth, and that's a different disease. And then melanoma can arise in the palms of the hands, soles of the feet, under the fingernails. Those are also different. Those are all kind of skin melanomas, but if you look at these are definitely different. So eye melanomas, melanomas arising in the mouth there, conjunctival melanomas arising from that lining of the eye. These are very, very clearly different. And as you can see in the percentages, these are far less common. So ocular melanoma, we'll see maybe 2,000 cases a year in the US. Mucosal melanoma, it's going to be even fewer than that. So these are very, very uncommon diseases. So what I want to focus on for this talk is really taking what all the other speakers have spoken about. How does immunotherapy, how does targeted therapy, how does this apply to these other melanoma subtypes? Because all of the nice research that's been presented before, that's really been done in the context of skin melanoma. It's a little bit of a hard talk to do, so I'm breaking it up into immunotherapy for mucosal and uveal, and then targeted, and we'll go from there. But just briefly, again, mucosal melanoma, very uncommon disease. about half of them that occur, so maybe 1,000, will occur in the head and neck area, in the mouth or in the sinuses. About a quarter will occur in the anorectal region. About a quarter will occur in the vulvovaginal region. And if you look at these patients and how they do, unfortunately, they will generally do worse in terms of outcomes when compared with the skin melanoma patients. And part of that may be due to later diagnosis. Maybe it's diagnosed at a later, more advanced stage, but a lot of this is just, it's a more aggressive disease. This is a little bit of a complicated slide, but some of the talks previously have talked about these BRAF mutations that we find, these NRAS and KIT mutations. And one point that I want to make here is that not only is mucosal melanoma different from skin melanoma, but it may be that mucosal melanoma arising from different parts of the body are different. And so, just for instance, if you look at these two different series, these folks here, let me get my pointer up. These folks here looked at 57 different mucosal melanomas arising from the mouth, and this group looked at a larger number of mucosal melanomas arising from the nose area or the sinuses. And just as an example, if you look at the percentage of patients with an NRAS mutation, which is one of these drivers, there's a striking difference in that with NRAS in the oral cavity, none of 57 cases had that NRAS mutation, whereas still in the head and neck, but just a different part, 19% of the sinonasal mucosal melanomas had an NRAS mutation. So I don't know that this is directly comparable. This is kind of an interesting finding, and it suggests that there may be differences even within mucosal melanoma subtypes, suggesting this is a really complicated disease. Because these diseases are so rare, there is not a lot of information for us to use to kind of guide judgment or understand how these patients are going to do. And a few years ago when I was at Memorial, a lot of us, Alex Shustari, who's still there, kind of leading the mucosal and ocular program there, we put together, which at that time was the biggest series of mucosal melanoma patients, and we just wanted to know, how do these patients do? How do they respond to systemic therapy? And that question had never really been asked before. And so we looked at 81 patients with mucosal melanoma who were treated at Memorial during this time period. And we had our radiologists look at the scans. We looked to see what their treatments were. And you've seen a number of these waterfall plots. But I think what you'll see here is that as opposed to kind of that BRAF experience where patients with BRAF melanoma treated with a BRAF or a BRAF MEK drug, most of the lines went down. That is not the case here. It's a very heterogeneous group, but I think this just supports the argument that the treatments we have for mucosal melanoma don't really work that well. 13% of patients will have some degree of shrinkage. A lot of these patients were getting chemotherapy. This was in the chemotherapy era when we put this series together. Since that time, a larger series, and this was a great series, which was presented by Dr. Larkin at the Melanoma Congress in I think last November. But this was a great series looking at how does immunotherapy work in this disease? Because before this series, there were only smaller kind of data sets that we had available. And so these investigators worked with Bristol Myers Squibb, who make ipilimumab and nivolumab, and they looked in these patients and just looked at the outcomes of the mucosal melanoma patients treated on these prior studies of nivolumab or ipi and nivo or ipilimumab alone. And you can see that it's a reasonably sized data set, again, in this rare cancer. So 86 of these patients got nivolumab alone, 35 got ipi and nivo, 36 got ipi alone. And this is how the patients did in terms of disease control. And so you can see here, I'm sorry, I wonder if the pointer might work better. So what you can see here, this green line is how folks did if they were treated with ipilimumab. And you can see that you want to be up here. If you're up here, the disease is controlled forever. But most patients don't get too much benefit here. Whereas if you got nivolumab or ipi-nivo, you did okay. And so this shows that there is some activity with immunotherapy in mucosal melanoma. If you look at the likelihood of tumor shrinkage, with nivolumab in this data set, you can see that about 23% of patients with mucosal melanoma had tumor shrinkage to nivolumab. About 37% had tumor shrinkage to ipi-nivo, and less than 10% had tumor shrinkage for ipi. So again, it's showing there is some activity, but compare this to how the patients with skin melanoma did. For nivo, cutaneous melanoma, likelihood of shrinkage is 40%. For mucosal, it's 23%. For the combination therapy, it's 60% versus 37%. So the outcomes are worse. So it can work, it's just not as good. So there is definitely interest in immunotherapy, mucosal melanoma. It can work. This is a standard therapy that I think is very reasonable to do. But one of the big questions for us in the skin melanoma field as well as mucosal melanoma field is, after surgery, what can we do to reduce the risk of this coming back, right? Because that's the time that, if we can surgically resect and maybe give some medicine, that's our greatest chance of a cure at that point. And so to that end, I'm working with Dr. Shustari and one of these NCI cooperative groups called the Alliance to try to develop a trial of immunotherapy a little bit before surgery and then after surgery to see if we can prevent it from coming back altogether, given that kind of evidence of activity. And so the way this study is designed right now is that for patients who are diagnosed with mucosal melanoma, I don't know if that shows up too well, but they're going to get maybe 1 or 2 doses of ipi-nivo beforehand. Then they go to surgery, and then in this study, half of the patients are going to get further PD-1 therapy, and half of the patients are going to get a placebo. And during the question-and-answer period, there may be a lot of questions about placebo studies. Is this the right thing to do? Because we want to do trials that are completely ethical, and we can talk about that later. But right now, this is the proposed study design. If this study actually gets launched, this will actually be the only clinical trial for patients with mucosal melanoma active that I'm aware of. So this is a major unmet need, both in the metastatic setting as well as kind of in this perioperative setting. In terms of eye melanoma, this is a disease that comes from these melanocytes or pigment cells that sit in what's known as the choroid, the uveal tract of the eye, which is made up of this kind of the middle portion of the eye between the white outer part and the inner retina. It's also made up of the ciliary body and the iris of the eye. And again, it's an uncommon disease. It is biologically distinct. It is a very challenging disease to treat. How well does immunotherapy work in this disease? Well, there have been a lot of series looking at does ipi work? And it can. Again, but if we look at ipilimumab in this disease, the likelihood of tumor shrinkage is 5%, a little bit of disease control, but it's really the minority of patients with eye melanoma who are going to benefit from this drug. In terms of how well does nivo or pembro work in this, or PD-L1 antibodies, before ASCO of this year, which is coming up soon, this is basically the data that's been out there. Of 7 patients treated at the Mayo Clinic with anti-PD-1 therapy, 2 patients had tumor shrinkage, 1 patient had some duration of disease control. And in this study of a PD-L1 antibody, there were some patients with uveal melanoma had some duration of control. But what I can tell you is at ASCO, it's a big question. Does PD-1 work in uveal melanoma? And there are actually going to be multiple series presented. The bottom line is that in the largest series, which I was fortunate enough to be part of, the likelihood of tumor shrinkage is 3%. And that's a 58-patient series. There are going to be a couple other data sets coming from France and from the University of Pittsburgh as well. But I think the bottom line is it can work, but it is by far just in the minority of patients. Okay? Why might that be? Just going a little bit into the biology, you heard a lot before that mutational burden, neoantigen burden, may increase the likelihood or does seem to increase the likelihood of a response to immunotherapy. And if we look at that plot that Dr. Sullivan showed before, but this is kind of in a different format, it's a different data series, but cutaneous melanoma has a lot of mutations, and that's this bar here. It's always on the far right of that curve. This is uveal melanoma. It has very, very, very few mutations. And so that's playing I think, a part of why immunotherapy is so challenging in this disease. Doesn't mean it can't work, it just means it's a little bit harder. There are other strategies that we can use to try to kind of harness the power of the immune system to fight this disease. I think it was Dr. Sullivan, Dr. Ferries spoke about something called BITE technology, or these bispecific molecules. I think other folks have shown a little bit about this kind of interesting drug called IMC-GP100 that is kind of this bispecific that binds to something called GP100. And GP100 is one of these melanoma antigens. Like if you look at melanoma, it's got a lot of this GP100 protein on the surface. But it turns out that, sorry, this doesn't project that well. But here, this is kind of, you can think of this, each dot is a sample of cutaneous melanoma. And some of them have high levels of GP100, some of them have low. So most skin melanoma expresses that. But interestingly, if you look at uveal melanoma, they all express it, but they all express it at very high levels. And so this GP100 target may be actually even more important in uveal melanoma than it is in cutaneous melanoma. One of these bispecific type molecules is this thing here, which is basically an optimized T-cell receptor. So this is something that binds to GP100. So anything that expresses GP100, this will bind to. And the other end binds to CD3, which basically brings T-cells together. So this drug brings the T-cells, your immune cells, directly adjacent to the melanoma cells. And in one of the prior clinical trials that was conducted, they did treat, and this was what was presented, 5 patients with uveal melanoma. And this is a waterfall plot, a very small one, but it's a waterfall plot, where we did see some degree of tumor shrinkage in patients with ocular melanoma. And there's more data that will be presented at ASCO this year showing activity in a larger set of patients with this disease. And so, although the immunologic checkpoint inhibitors, IPI or PD-1, didn't work in the majority of patients, it does not mean immunotherapy can't work. And so this is just another way to try to kind of potentially change that. And so there are trials now in uveal melanoma for this disease. They're ongoing. Dr. Hamid is participating in some of these trials, and fingers crossed that we'll find an effective therapy here. In terms of clinical trials for ocular melanoma, unlike mucosal melanoma, where there are no active studies that I'm aware of, there are about maybe 15 to 20 active for uveal. And some of these are immunotherapy trials. Although the retrospective series suggests that PD-1 inhibition may not work, those are retrospective studies which have inherent flaws. And so there is a prospective clinical trial of pembrolizumab for patients with uveal melanoma that's ongoing. Dr. Patel, who runs the uveal melanoma program at MD Anderson, is doing a prospective trial of the combination of ipilimumab and nivolumab. And so these are important studies. We need the answers to the question of, how well or how not well does it work? You heard about TILs by one of the prior speakers, and there's actually a TILs program at the NCI. So once that program opens up again, we'll have, we will have some prospective information regarding TILs. And then there's a GP100 program as well. So just for the latter half of the talk, I'm just going to switch to targeted therapies. While there are clear clinical differences between these different melanoma subtypes, those clinical differences are also kind of mirror these differences in molecular profiles. And so when we talk about BRAF mutations, these are primarily in the patients with melanomas arising from skin without sun damage. But interestingly, if you look at the less common melanoma subtypes, like those with chronic sun damage, the mucosals, the acrals, these less commonly have these BRAF alterations. You can see NRAS alterations, but these more commonly have KIT alterations. And so something that has been of interest in some of these less common melanoma subtypes is, well, what if we shut down KIT in those cases? That's been a little bit of a challenging story, but I think what I can say is there are some cases, if properly selected, where we can get some durable benefit. And so this is a patient who I treated a long time ago on one of our first KIT-targeted trials, who had a vaginal melanoma with a KIT mutation and high levels of that KIT protein. And when I saw her, she had a lot of vaginal bleeding, a lot of pelvic pain. And on the MRI, this is the tumor there that's very abnormal on PET. And within, actually, it was even within less than a week of starting therapy, the bleeding stopped, the pain went away. So she had a dramatic clinical benefit. And you can see how quickly the tumor shrank just within 6 weeks. And this patient did well for a long, long time, although it ultimately did come back, unfortunately. Why I say this is complicated is that unlike the BRAF mutations, which are very commonly the same BRAF mutation, they're most commonly this V600E BRAF mutation, for KIT, you find mutations everywhere, all throughout that protein. And we don't know what some of those mutations mean, and we don't know if these drugs that we have shut those mutations off, if they are functional at all. But what's been interesting is that if you look at all the KIT responders, so all the patients with mucosal melanoma or whatever who had a KIT alteration who did well, almost all of them had certain types of KIT mutations. And so it may be that there's some KIT mutations that won't respond to these treatments, but there are some that will. And so that's why I say it's complicated. And so I think KIT inhibition, there is a role for it, although it has to be done in a very thoughtful type fashion. This is in the NCCN guidelines based on work that a number of us have done. So it is available. We can get this covered through insurance. For uveal melanoma, I told you again that this is a very mutationally bland tumor. And, in almost all cases, we find these recurrent alterations in these genes called GNAQ and GNA11. So we've done a lot of this fancy molecular profiling. We know what the mutations are in almost all cases, and we know what the potential drivers are. The question is, can we take advantage of those? And this has also been a very challenging story. One of the recurrent alterations that we find in uveal melanoma is not in BRAF, but it's in either GNAQ or GNA11. And there are other genes actually that have been found that have been altered that also functionally do the same thing. But one of the key outputs of this, or results of this, is activation of the MAP kinase pathway. So it's the same pathway that's activated in uveal melanoma as in skin melanoma. It's just activated a different way. And so just like in the skin melanoma story, we were very interested in seeing what happens if we shut it off. And the first drug that we could kind of get our hands on at that point to test that was a drug that shuts the pathway off at the level of MEK. And so this is kind of what trametinib does and so forth. And so we wanted to block this MAP kinase pathway at that level with a drug. And in the first trial that we did that tested this, it looked like patients who got the MEK inhibitor had better disease control than those who got chemotherapy. So that was interesting. It was promising. Data like this had not really been shown before, or we hadn't found a drug that did anything like this before, so we were very excited about this. And based on these data, AstraZeneca, which is a company that makes selumetinib, launched this big international trial where patients were randomized to the MEK inhibitor with chemo versus placebo with chemo. And again, we can talk about the placebo issue later. It's an important one. And so this trial opened and closed very quickly, but unfortunately, this is the curve that we saw in our prior trial where selumetinib did better than chemotherapy. But in this international trial, there was really no difference. The curves overlapped. Importantly, I would just point out that the design's a little bit different in that in our prior trial, patients got selumetinib alone. Here, we're combining it with chemotherapy to try to make it work better. In terms of the waterfall plot, we did see some real tumor shrinkage cases in our phase 2 trial. We really didn't see that so much on this international trial. So again, I was personally very disappointed in this, but again, kind of like the immunotherapy story in uveal melanoma, maybe that we're just not doing this the right way. It's not that immunotherapy can't work, it's just we have to do it differently. It may not be that MEK inhibition does not work, it may be that we have to do it differently. And so one avenue of research that's ongoing in this field is to try to see if we can tweak how we do MEK inhibition. And so, different MEK inhibitors are different. They work differently, and we're going to present some data about a different MEK inhibitor at ASCO. But it also may be that we have to dose it differently. These treatments, these pills, we give every day. And that may not be the right way to do this for a number of reasons. And so we're going to be testing different schedules to try to see if we can give this better. But also we have to figure out how can we combine drugs, like we're combining the BRAF inhibitors with other drugs to kind of hit those bypass pathways and not allow the cell to kind of continue to be activated despite effective MEK inhibition. And so there are a number of MEK-based trials that are ongoing, some by us, some by others, looking at inhibiting the MAP kinase pathway or the PKC inhibitor pathway with other pathways. And hopefully, as we pursue the immunotherapy angle, hopefully we can figure out how to get targeted therapy to work as well. And so, this is kind of how I think about treating mucosal melanoma and uveal melanoma. This is not endorsed by any sort of body, but this is kind of my general thought. That if we look at chemotherapy, it does not seem to work very well in patients with mucosal melanoma. It does not seem to work very well for patients with uveal melanoma. So this is not something that I think about doing, front line. Immunotherapy can work in mucosal melanoma. And so this is very reasonable to do, I think. We need to improve those outcomes, but there are standard of care options that are immunotherapy for patients with mucosal melanoma. With uveal melanoma, I think, we have a lot of retrospective data to suggest that these checkpoint inhibitors don't work as well in this disease. So, I'm a little bit cautious as to whether or not to do that frontline in this disease. It's not right or wrong, but we just have to know what the data is showing. With targeted therapy with mucosal melanoma, if they have BRAF mutations or RAS mutations, we can treat them much like we're treating patients with cutaneous melanoma with those alterations. With uveal melanoma, I don't know that there's a clear clinically available targeted drug that I would do outside of a clinical trial. There are MEK inhibitors that are available that you can prescribe, but again, I think we still have to figure out how to give those the right way. And for both, I still strongly encourage clinical trials. This is the only way that we can make progress, and that's why I think you guys are here. We have to work together to kind of do these studies. So I'm going to leave it at that, and thank you guys very much for your attention.